Hi, my name is Huie Lin. I'm the director of the Adult Congenital Heart Program here at Houston Methodist. And with this, we're going to be kicking off a new series of very exciting projects. Today, we're going to be talking about how we were recently approved for a funding award through the Eugene Washington PCORI Engagement Awards Program, an initiative of the Patient-Centered Outcomes Research Institute, or PCORI. Specifically, we're going to be building capacity for patient-centered outcomes research through a South Central United States Adult Congenital Heart Disease Stakeholder Collaborative over the next 2 years.
I'm very excited to be involved with this PCORI project because it deals with congenital heart defects. Many babies are born with congenital heart defects, and today they're living to be adults.
Of course, we have cardiologists, but they're for acquired disease for the aging heart on the general population, but nobody that specializes in children or adults that, have had long-term care and congenital issues. And so that's where this project comes in.
As most of you already know, here at Houston Methodist, we've been striving over the last several years to become more and more patient-centered through developing our Patient and Family Advisory Board, through incorporating patients as educators through both our annual Adult Congenital Heart Disease Symposium, as well as our monthly DeBakey CV Live program. And then most recently, we started building a process for creating congenital heart disease awareness throughout the entire Houston Methodist system.
I know what I want as a patient. I know what my patients that I work with would want as far as patient-centered outcomes research, but how does that really interpret into a research question or research that the broader population could use? And I think that that's the challenge we're going to face as patients who are actually leading this process and developing and helping to eventually develop the research or the research questions or disseminate the research and those kinds of things.
And so it's no surprise that from this patient-centered education system that we would want to move on to developing patient-centered innovative care, and then from there work with the Patient-Centered Outcomes Research Institute to develop patient-centered outcomes research in this region.
It's nice to have a patient-led process. And Dr. Lin and his team have really stepped aside and let us, the patients, lead the process. So sometimes it's scary because we don't know what we're doing yet, but I think in the end it's going to lead to a very patient-centered result.
And so today we're going to talk about how we're going to recruit stakeholders, train them in research methods, and then develop patient-centered outcomes research programs. And through these three areas, education, innovative care, and research, we plan to really lead medicine as far as patient-centered care in adult congenital heart disease.
I've noticed a severe underrepresentation of adults in not only the congenital heart disease research realm, but also within the field itself.
And so through my connection with Dr. Lin, he contacted me about this project and I immediately joined on, because I realized that where I live, my geographic region, there is no help for patients like me.
Where does adult congenital heart disease data come from? Well, it turns out the majority of the high-impact studies have come from primarily the United Kingdom, Northern Europe, because of their socialized medicine and large patient registries, but then also in the United States and in Northern America from Canada, as well as the Northeast and the Midwest. Unfortunately, what this does is it doesn't necessarily talk about the patients that are in our region. Here in our region, here in the Houston area, as well as in Texas and the surrounding South Central areas of the United States, we have a very different type of patient population. And as we know, adult congenital heart disease comes from at least some degree of influence of genetics. And what that means is what might be right for a patient from, say, the United Kingdom or Northern Europe may be very different from a patient from our region in the United States.
I think when we think about the adult congenital heart disease population, we think of a very heterogeneous group. And I think that plays right into patient-centered outcomes research, because I think the research is so integral to this population.
And so the goal of this 2-year project is to build an adult congenital heart disease stakeholder collaborative and to recruit patient stakeholders as colorful as our region of the United States. Our next goal is then to train them in research methods and enable them to be equal partners in outcomes research. And then we want to report these efforts on a regular basis through this series of videos so that we can increase the visibility of our patient-centered outcomes research program, and then also allow other people to learn from our process, both our successes as well as our failures, in how they can build their own adult congenital heart disease stakeholder collaborative for patient-centered outcomes research. Finally, we want to build the infrastructure to allow for sustained patient-centered outcomes research and successfully apply for funding so that way we can actually participate in patient-centered outcomes research in this region with this stakeholder collaborative that really represents the colorful region that we have here in the south central part of the United States.
I see these patients and these parents that come to me with research all the time, and so much of my work has become interpreting research and helping them understand research.
Despite the fact that there's more adults than children living with congenital heart disease, there's still so little known about what's going to become of us as we grow into adults. I think it's really important that we invest time and energy into researching long-term outcomes of congenital heart disease.
We are already in phase 1. We've started building our steering committee, and we will start to soon recruit stakeholders as part of our stakeholder collaborative. In phase 2, we will begin training in patient-centered research techniques. The Patient-Centered Outcomes Research Institute has already developed an excellent module that will actually allow us to train in these areas, and we will implement those modules. Finally, during phase 3, we will ensure that we have a self-governance established and a self-renewing recruitment of stakeholders and the infrastructure to allow us to truly participate in patient-centered outcomes research, and we will begin our patient-centered outcomes research portfolio. As mentioned, these are the research fundamental modules that the Patient-Centered Outcomes Research Institute, or PCORI, has published. And in fact, we will be using these consultants to help us to go through these modules and to learn about engagement in patient-centered outcomes research, as well as to learn how to actually perform patient-centered outcomes research through our patient stakeholder collaborative. One of the most important things that we will develop is an online portal through which we can publish all of our materials. And the second most important thing is this series of video blogs, which we're kicking off with this series today, in which we will allow continuous reporting of our progress on a monthly basis throughout the entire 2 years of developing the stakeholder collaborative.
What is it that we want? But we definitely want a patient voice behind it. What types of things can we do to bring better quality care to give longer lives to these patients?
We hope that you can join us. This is a very exciting time both for us here at Houston Methodist and our adult congenital heart program. We also believe this is a very exciting time for patient-centered outcomes research here in the south central part of the United States.
I feel like we've done a lot since we started this project, and I'm very excited to see where it's going to go as we move forward.
Again, thanks for joining me. This is going to be a very exciting time. And let's go back to the studio. Questions. Remember, you can join us on the web at pollev.com. That's POLLEV.com, and you'll enter DeBakey, DEBAKEY, and respond to the activity, and you can send us your questions. Also, you can join by text message by texting DeBakey, DEBAKEY, to 37607 and send us your questions by message. And with that, I want to announce the next really exciting phase of our DeBakey CV Live Adult Congenital Heart Disease edition, and that is the tech update. With us today is the amazing Dr. Athar Qureshi, who is the director of the Cardiac Catheterization Laboratory at Texas Children's Hospital, and he's going to be talking to us about a very exciting development. Dr. Qureshi, it's great to have you.
Well, thank you very much, Dr. Lin, for that very kind introduction. And it's great to be here with you and your team who are doing amazing things for adults with congenital heart disease. And it's obviously great to be here. This institution has a great legacy from Dr. DeBakey and others. So thank you very much for having me today.
Wonderful. So recently we learned that there's a very exciting development in our field, and Dr. Qureshi is doing a lot of wonderful things with it. So Dr. Qureshi, we just found out that there's a new technology that was approved by the FDA. Can you tell us a little bit more about that?
Yes, that's correct, Dr. Lin. So this technology that was recently approved by the FDA is called the Harmony valve. And this is many of us, like yourself and myself and others who treat patients with congenital heart disease, disease, adult patients with congenital heart disease, see this as essentially a game changer. This is a valve that can be implanted to relieve regurgitation or leakage of the pulmonary valve that many patients with adult congenital heart disease have.
Wow, that's fantastic. So we've heard a little bit about transcatheter valves in the past. There are some other valves that are already in existence. So what makes this one different, and why is it such a game changer, do you think?
Sure, and maybe we can play the video and we can talk through that as well. But it is, we can, as you can see in this video here, this is the heart that is beating, and you can see the patient has a patch over the pulmonary valve area. So many of these adults with congenital heart disease will have leakage. As you can see there, blood is flowing out to the lungs but also leaking. This is the valve, which is a larger valve, and it is implanted without surgery. So that is definitely an advantage for these patients. This is just depicting how, an animation depicting how this valve system is advanced over a wire, and you can see there into the area where the patient should have a functioning pulmonary valve. And then this is a sheath that we use to uncover the valve, and you can see here the valve is being uncovered, and it's uncovered slowly so that the operator can really fine-tune the position of the valve. And here you can see the middle portion is being released, and then the valve will eventually be deployed completely once the operator is satisfied. Here you can see that the sheath or the delivery system is being withdrawn now, and all that is left is the valve and the wire, which will also eventually come out. The wire will come out. So this valve has been implanted, as you can see here, into that pulmonary valve area, and now this patient no longer has leakage back into that ventricle, and blood is flowing out to the lungs in a more normal fashion.
Wow, that's really, really thrilling. So when I think about this, I think this is going to really change the game for many of my patients who don't necessarily have a prosthetic valve already. Am I thinking that correctly?
That is correct. That is correct. If you look at, there are some technologies available and transcatheter valves available, but generally those valves are meant to be placed in conduits. So if a surgeon has already constructed or placed a conduit, which can be in the form of either a tube or a cadaver valve, or there are other conduit valves. And so that has limitations because not all of our patients and not all of your patients have conduits or connections, artificial connections between the right ventricle and the pulmonary arteries. In fact, the valves that are used, one example is the Melody valve for those conduits, they really can treat only about a quarter of patients who you and I and other doctors treating adults with congenital heart disease see. And so this is a game changer. So this will cater for the needs of those that 3/4 of patients that we are not able to treat right now in a non-invasive way.
Yeah, that's really exciting. Yeah. So I think when I think about the patients that I'm usually dealing with that could potentially benefit from this, we're then talking about, say, for example, typically tetralogy Fallot patients, the ones who had that initial surgery that was the full repair, right? And typically what they've had done is they've had the patch over the outflow tract or the pulmonic valve, and it's really left them with wide open regurgitation. And at this point in time, typically we would most of the time send them for open heart surgery, for a second heart surgery, right? And I guess what you're telling me is that there's a potential that this valve, the Harmony, it's called, could potentially reduce the need for that second heart surgery. Am I getting that correct?
That's absolutely correct, Dr. Lin. So there is a potential that it could reduce the need for surgery, although it's yet to be seen in how many patients will that hold true. They've actually now come out with a newer generation of the Harmony valve. The prior generation was not applicable to all patients, and this has sort of extended the reach, if you will, further. So there will always be a need for surgery for patients, but absolutely, as you said, this really expands our reach to help these patients, and a large percentage of patients that we cannot implant transcatheter valves in will now be able to undergo implantation of a transcatheter valve, for example, the Harmony valve, which was recently approved. And I think that this is really big for patients who've had multiple surgeries over their lifetime and have other comorbidities, in addition to the recovery time and all the other benefits that we see with less invasive therapy.
Yeah. So let's break it down a little bit, because I think some people who are listening to us now and thinking about the technology may be asking the question, well, okay, so I've heard some things about transcatheter valve technology like the Sapien valve. You mentioned a little bit about the Melody valve, and now we have the Harmony valve. So what is the difference between, say, the Sapien valve and the Melody valve, and then the Harmony valve? How is the Harmony valve different from those other two technologies?
That's a very good question. The Sapien valve was initially designed for aortic implantation in adults, so what we call, as you know, the TAVR procedure or TAVI procedures. And that has now been implanted in pulmonary valve positions and in native outflow tracts, which the Harmony valve aims to treat as well. The difference, if we just take them, we can break these valves down one by one. If we look at the Sapien valve, it is a balloon expandable valve. So the technology is also different from the Harmony valve, which I'll come to in a minute. So it's a balloon expandable valve, and there are also size limitations. It's available in size up to 29 millimeters. Many of our patients and your patients, unfortunately, when they grow as adults, their outflow tract area is much larger than 29 millimeters, and so we're unable to implant a Sapien valve. The Melody valve is actually a smaller valve, and that can be implanted up to 22 millimeter size, and generally it's implanted in conduits, although in some patients it can be implanted in a native position, but generally the approval is for conduits, which as I mentioned before, in fact 3/4 of our patients do not have conduits. It's also a balloon expandable valve, very similar to the Sapien valve. The Harmony valve, as you can see right now on this cartoon animation that is being played, is a self-expanding valve, and it's available in larger sizes. So this is a valve that is really nice. It has a nice design to be implanted in that area for patients who have really dilated, what we call right ventricular outflow tract valves.
So how does this work? So it looks really nice. It looks like it's springing open as you deploy it. What is it doing? Why is it self-expanding? What's it made out of that makes that possible?
Sure. So the material has memory, so nitinol memory, and that's what we call that allows this valve to be have a self-expanding properties. So it's really nice in that regard, and the radial force of these valves up until now, which have been tested, seems to be very good.
And then it looks like there's some sort of fabric covering on the outside of that. That seems like it's kind of important. Can you talk about that?
Yes, it is important. And as you know, you can see here the valve is sort of in the center of the area, and the fabric is around that, is providing some sort of support to that to the valve also. And it's also very helpful in terms of preventing any paravalvular leak around the valve.
Well, let's talk about that. So what is paravalvular leak? It sounds like something very bad.
Yes, that's a good question. So paravalvular leak in this situation would be a leak that is around the valve leaflet. So you can implant the valve, but there still could be leakage around the valve frame. Generally, it's mild and well tolerated in the pulmonary position. But nevertheless, if we are embarking on implanting a valve in a patient, we would want that patient to leave the cardiac catheterization laboratory with as minimal leak as possible. So that's what a paravalvular leak is.
Gotcha. Okay. And then, so let's talk about the valve itself, because that's probably what most people really want to hear about. So it's clearly not a mechanical valve, right? So what are we putting in there?
Yes. So this is made of porcine pericardium, the leaflets of the valve. So and it is hand sewn. And there are many stitches involved in this valve, where they are hand stitched to the frame, the entire covering. I was surprised to hear how many stitches and how much time it takes to make this valve.
Gotcha. So bovine pericardium. So we're talking about the heart sac.
Porcine pericardium.
Porcine pericardium.
I may have misspoke.
The heart sac around a pig's heart.
Right.
So they harvest that, they fix it in a chemical so that it's durable.
Correct.
And then they cut leaflets out of that.
That's
and
correct.
then sew it in by hand.
Correct.
Into each of these valves.
Correct.
That's really incredible. That's fantastic. So I guess what are the things that? So if I'm a patient and I'm thinking about, is this the right thing for me? What are the things that I have to think about, what should I worry about? should I talk to my doctor about having this done? I mean, it's time. I've been worried about needing a valve replacement for 5-6 years now, and we talked about surgery forever. What can I do? What should I worry about? How should I be thinking about this?
That's a very good question. Oftentimes patients come to us, and with any new technology there is a worry, and that's understandable. There's a worry both from the patient's point of view and also from our point of view. Any new technology, we want to make sure that the data is good, and that's why this announcement by the FDA was huge for approval. So all of this has gone through a rigorous trial, and now it's been approved by the FDA. So I think patients hearing that this is now an approved device by the FDA will help answer some of those questions and address some of those worries that patients have. The other thing is, I think it's very important to talk to your doctor, because many times patients have not only pulmonary valve leakage but other coexisting problems with the heart, and it may be that actually surgery is the way to go. So it's very important to talk to your doctor about what the best way to help your heart condition is. But generally speaking, if this is the only lesion or problem a patient has, then from what the results we have seen, it's very exciting. And we haven't seen any really bad or serious side effects that would cause us pause or worry. This has gone through very rigorous trials. We were part of this here in the Texas Medical Center and honored to be part of that. So it's been through a very rigorous trial process. The FDA has evaluated it. I think that many patients will have that concern still, that there hasn't been 10 years follow-up on it, and that's a legitimate question or concern. There has not, but the short-term data that we see is very promising. If we extrapolate from percutaneous valve data, and this started in the early 2000s, so percutaneous pulmonary valves, for example, the Melody valve has been around for 2 decades or so. And so we have a lot of data on the safety and efficacy of that valve. This is an extension of that technology. And so that's how I think we should present this to our patients, that yes, it is a new technology. The short-term data on safety and efficacy is very encouraging. And based on the track record of valves and how they're being tested, we see this as a very exciting technology. And so I think that patients would definitely be very happy to hear about that. But if there are any questions that they have, of course, they can look at some of the publications or talk to their doctors about the intricate details of this valve.
Okay, so I'm thinking about this now as a patient, and I'm thinking I want to talk to my doctor a little bit more about it. How do I get prepared for it? So if I'm thinking about I want to do this, what are some of the steps that get me forward to actually having the procedure done? So what kind of testing do I need to have done? What kind of visits do I need to have done? And then how do I prepare myself to actually have the procedure done? And then what can I expect afterwards?
Very good questions. So I think the main point or it's very important to have consistent follow-up with your doctor. So I think maintaining consistent follow-up with your adult congenital doctor is very important. And he or she will have done tests along the way. And in fact, as you know, Dr. Lin, we monitor this new technology in our field. And so your cardiologist will have heard of this technology. And it could be that they have been waiting for this technology if you didn't need anything in sort of an urgent or semi-urgent fashion, which is usually the case. So I think that expect to hear this from your cardiologist for sure. I think maintaining appropriate follow-up, there is a lot of testing involved. So first of all, for example, exercise testing, echocardiograms to see the function of the heart, how much leakage there is. And then we look at more quantitative data by MRI, so a cardiac MRI, where we can measure the exact volume of the heart and how much leakage is coming across that pulmonary valve area. And based on that, we can then tell you whether indeed you need a procedure now or not. Many patients can actually tolerate having leakage of the pulmonary valve for many, many years, if not decades. So the mere presence of leakage does not mean that a patient requires pulmonary valve replacement at this time. However, if there are other parameters that are out of normal range on the MRI and other testing, then it may be time for you to have your pulmonary valve replaced, and it's up to your doctor to decide how to do that, whether it can be done surgically or via transcatheter method, which, as we are discussing today, is really exciting for us to hear about this new technology. Finally, I think there is a little bit more testing involved also. In addition to MRI, patients will require a CT scan, which, Dr. Lin, I know you're familiar with from adult TAVRs, and that really is used as a screening test, if you will. So patients can be assured that their doctors and implanters, if they sort of qualify for this technology, have really gotten a very good roadmap before they go into the procedure. And I think that's really exciting. Most of the procedure is done before we even start the procedure. We know exactly where we would like to implant the valve, what size we would like to use, and other nuances of the anatomy are sort of teased out before we go in. So the CT scan helps us in that regard.
Great. And we actually have a question here. So does calcification of the native valve create issues with using the Harmony valve?
It's a very good question. It has not. In fact, if you have a large outflow tract valve that does not meet criteria for implantation of other valves, calcium actually can be helpful in this situation. So what implanters, those who have implanted many and many of these in the U.S. have found is that small areas of calcification can actually be helpful for the valve to this technology to seat well. Now, I will say if there's extensive calcification, of course, that can affect, because then the valve, it will make it difficult for the valve to open in some instances. But generally, patients with pulmonary regurgitation, as you've seen in your practice, generally they don't have a whole lot of calcification in this area, as do, for example, adults who are undergoing a TAVR.
Yeah, great. So let me sort of step back a second and try to see if I can paint the picture correctly. So if I'm a patient, say, who was born with tetralogy Fallot and has had a lifetime at this point, say 15, 20 years of pulmonic regurgitation from my initial surgery, I've been followed probably annually with an echocardiogram and then intermittently getting a cardiac MRI to assess my right ventricular volumes to see when it's about time to have the valve replacement done. At that point in time, your team would basically meet with me and say, should I have open heart surgery or should I have transcatheter valve in the form of Harmony? And at that time, maybe I might get a CT scan to see whether or not the Harmony self-expanding stent would fit my anatomy. Is that right?
That's absolutely correct.
And then once that's done, then if it looks like I'm a good candidate for the Harmony, if it looks like on my CT scan that it's going to work, then we proceed.
That is correct.
And so talk to me about the day of the procedure. How does that actually work?
Right. So many of you may have already had a cardiac catheterization. So in essence, this is not very different from those procedures. So if you, as an adult, or remember any of your cardiac catheterizations, or even remember some of your heart caths when you were a teenager or child, it's really no different than those procedures. What you can expect the day of the procedure is, again, your cardiologist, interventional cardiologist, would have met you before the procedure and talked over about the risks and the benefits, but you can also expect to meet the team the day of the procedure. This is a relatively new procedure, so we definitely understand that patients still may have last-minute questions, and just like we do for all of our patients, we'll meet them the day of the procedure, and they'll be prepped in the same way that they have been over the years for any cardiac catheterization. These procedures, in general, are done with general anesthesia, and I think that it's very important from a few from the standpoint of a few areas. One is we want to make sure that the patient is comfortable and we have good landmarks for implanting the procedure. That being said, even if these procedures are done with general anesthesia, patients can expect to be back into the recovery area without any breathing tube or any assistance. And patients will leave the hospital, we anticipate, the next day. So there is monitoring overnight. Even though this is a less invasive therapy than, say, open heart surgery, it still involves placing a relatively large bore sheath in the groin. So we want to monitor patients for bleeding at the groin site, but also we want to make sure that the valve is functioning well by the time of discharge, and make sure that the valve stays in position, which by that time usually is the case, but we still want to monitor the patients in the hospital and then obtain appropriate tests the next day. So patients can expect an overnight stay in the hospital and then discharge sometime late the next morning. But generally, all patients who undergo these procedures should be walking within 6 hours of the procedure.
Wonderful. That's fantastic. That's really great. So, and that leads to the next question that everybody always asks me, which is, what is the downtime?
Yes, that's a very good question. So the downtime is much less than compared to open heart surgery. So open heart surgery, whereas it's obviously been around for a while, and our heart surgeons have fantastic results, of course, with this disease and these lesions, many years of experience. The recovery time can be quite prolonged, 6 to 8 weeks. With this technology, like I said, we anticipate patients to be walking within 6 hours. We do recommend that they don't perform any heavy exercise or weight-bearing exercise for about 5 days to a week. Just mainly we want to make sure that there's no bleeding at the groin site. So, but otherwise, daily activities one can go about. Again, within 6 hours of the procedure, the patient should be up and about and ready to do daily activities the next day.
Wow, that's amazing. That's really a game changer, again, like you said at the very beginning. Okay. So let's see. So talk to us. It just got FDA approved. We're thinking there's probably going to be a little bit of ramp-up time before it really rolls out to the average patient. Talk to us about what you think is going to be happening from that standpoint. I know it's a little bit early, but how, if, say, one of my patients wants to learn more about it now, they want to start planning for it, how do they go about doing that? What can they do?
That's a very good question. So patients, like us, they have access to so much technology nowadays, and we've already received phone calls from many patients that hey, we heard that the FDA has now approved this device. When can we have it implanted? And so we obviously told them about the steps involved. But I think that patients should contact their cardiologist and see is the technology available at their center, and if not, where's the closest center or the center that they would recommend this procedure to be done. Many centers initially the launch is going to be in a sort of stage-wise fashion, if you will, where some centers will, who particularly had experience during the trial, those centers will have access to the valve first. But there is a staged rollout, if you will, where other centers are coming on board slowly. So I would anticipate by the end of this year, a number of other centers will have had access to this valve, hopefully. So if not available at your center where you are seen, there should be a center near you where your cardiologist can direct you if you indeed need the procedure right now. Otherwise, it can be done at some other procedure, some other centers close to you or your center in the near future.
That's great. That's really fantastic news. Guys, so I missed a question. Is it still available? We'll take a second to see if we can get it back. Okay. So then I think the other major question that I want to make sure we talk about is we have all these other, oh, here we go. What would be the type of candidate to receive this new Harmony valve?
Yes, so the type of candidate would be any patient who has significant, first of all, who is either symptomatic, so has significant symptoms, or the right ventricle has been is deemed to be quite large by quantitative measurements that you and I and other cardiologists use. So based on MRI measurements, that would be the type of candidate to first consider for a Harmony valve. So there are a number of steps. So first of all, the patient, there has to be indications. Obviously, the patient has to be symptomatic, or the right ventricle or other areas of the heart have to be showing significant signs of need for replacement of the pulmonary valve. So those are sort of the clinical and physiologic indications, if you will, for the type of candidate to receive this valve. And then we talk about the anatomic considerations, and I think there are a lot of nuances with that, and that's where the CT scan comes into play. And so I think this is a very good question, because even we as providers, we can generally say at the first first visit that you require a pulmonary valve replaced. Whether you qualify for a harmony valve or not is a little harder to tease out, because whereas the technology is very exciting and this has expanded our reach, as we mentioned, we talked about earlier in the show, there is still a number of anatomic considerations that one has to sort of check the boxes on to qualify. So the CT scan is really key there. So once that CT scan is done and all the anatomic considerations are looked at by your physician, then your physician would get back to you about whether you qualify or not.
That's great. Wonderful. So, and then I guess the last thing that I sort of want to mention is just thinking about the field. So I think this is an exciting, wonderful development. At the same time, though, it seems to me as an interventionalist that there's still going to be an area for using melody valves, Sapien valve, these balloon expandable valves, right? It doesn't make it completely unnecessary to use these other valves that are already on the market. Can you tell me about how you would think about where you would want to use harmony versus the balloon expandable valves?
Yes, that's a very good question. I think that one of the issues is, so firstly, if there's a conduit and it's not very large, then we would prefer to use the melody valve or Sapien valve, because this valve, as you saw the design of it, this wouldn't function well in there. It wouldn't be allowed to open. It would be constrained in a small area, so it would not actually function well. So anybody who's had a conduit, most patients would qualify for either a melody valve or a Sapien valve. Now, the other, you bring up an interesting question, because this technology is not readily available to everyone. And so there are instances where a Sapien valve, which is a balloon expandable valve, can still work in the native outflow tract position. So if the native outflow tract valve, and that's that area as you saw in the animation that had a patch, if that is not very dilated, then you may be able to undergo implantation of a Sapien valve in that area that is readily available at your hospital, which would be nice, particularly if you don't have access to the harmony valve, which might take some time. So I think access issues will come into play, but like I said, this is now the approved device for the native outflow tract valve. So the way I see it is that more and more patients and physicians are going to want to go to this device first if there's a need to implant a valve in the native outflow tract position.
Yeah, and then so just to clarify for everybody who's listening, so native outflow tract means that you haven't had prosthetic device placed in there. So in other words, you don't have a cadaveric valve placed in there, you don't have a pig or a cow valve placed in there. Of course, the big thing that we have to make sure is very clear is that if you have a mechanical valve, that is not something that we can treat at this time with any of these transcatheter valve solutions. And then lastly, when we really think about bigger horizon as far as the field is concerned, this is just the first step in the enterprise to self-expanding valve solutions. Talk to us about what you hear about is coming out as far as things that are being studied right now.
Yes, so this is obviously not the only technology. This is the recent information that we received from the FDA, but we talked about the Sapien valve. So the company that designed the Sapien valve is also has a valve that is designed for, or a platform, I should say, not really valve, that is designed for this situation, the native outflow tract valve, that utilizes the Sapien valve, but it's a two-step procedure as opposed to a one-step procedure, where it's called the Altera valve, and so it uses a frame that is sort of similar to this, and then the Sapien valve is implanted within that. So I think, and there are other self-expanding valves that are used in the native outflow tract position in other areas of the world. So the United States is not the only place. There's the venous P valve, as you know, and other valves. So I think that, as is the case with any technology, we're only going to get better over the years. We mentioned that this technology started 2 decades ago, and nobody thought it could be implanted in a conduit, let alone native outflow tract valve. And now, we have the technology to implant these valves in the native outflow tract position. Yeah. So I think that these valves are going to get better over time, and I think that more patients are going to have access to them. For example, the harmony valve has 2 sizes, because the first size, many patients wouldn't qualify for implantation with the first size, and so the larger size with the different has expanded the reach. So I think that we're going to be able to implant more and more valves over the years by virtue of this technology evolving over time. So it's really, really exciting.
That is really incredibly exciting. Well, so I want to just reiterate my huge thank you to Dr. Qureshi for joining us today on our very first tech update on DeBakey CV Live, the Adult Congenital Heart edition. Not only has it been wonderful having you here, it's also been wonderful actually talking about this amazing new technology. As I like to say to people, this is an amazing time to be an adult with congenital heart disease, because the technology that is coming out to treat adults with congenital heart disease is just skyrocketing and expanding exponentially. So again, thank you, Dr. Qureshi, for talking to us about the Harmony and talking to us about this amazing new innovation in our field. And we would love to have you come back again at another time.
Thank you very much, Dr. Lin. It's been an honor.
Thanks for joining us. And as always, keep the conversation going. Find us on Twitter, Facebook, or YouTube. Send us comments or questions, and we'll see you next month.